The subcommittee will come to order. The chair will recognize himself for an opening statement. Created by the Balanced Budget Act of 1997, the Sustainable Growth Rate, SGR, is the formula through which Medicare reimburses physicians. Since 2003, Congress has voted more than 15 times for temporary patches, or doc fixes, to avert ever larger cuts to providers. Absent congressional action, providers are facing a reimbursement cut of approximately 25% on January 1, 2014. The uncertainty of the SGR threatens doctors' ability to continue practicing medicine and accepting Medicare patients, and endangers seniors' access to care. The time of temporary fixes and kicking the can down the road has ended. The bipartisan committee draft before us today permanently repeals the SGR and places us on a path to paying for innovation and quality, not volume of services, and puts doctors, not bureaucrats, back in charge of medicine. In the first meaningful reform policy to repeal the SGR since it was created, and a product of over 2 years of work by this committee. In March 2011, Representative Upton, Waxman, Barton, Dingle, Pallone, Burgess, and I sent letters to over 50 medical associations and societies, soliciting their thoughts and ideas on an SGR replacement. Since then, this subcommittee has held 4 hearings on what a new Medicare patient-physician payment system should look like. The committee has also released 4 draft SGR proposals this year, each more detailed than the last, with a comment period after each to invite public reaction. The committee draft before us today incorporates ideas and principles from the provider and patient communities, from Republicans and Democrats on the committee, and from our physician colleagues in the Doctor Caucus. It is not perfect, but I'm proud to have my name on this document along with Dr. Burgess, Representative Pallone, Chairman Upton, Ranking Member Waxman, and Chairman Emeritus Dingle. The bill removes the threat of the SGR. At the same time, it decreases the administrative burden on providers by streamlining government programs that have been layered on top of them for over a decade, thereby giving them more time and ability to care for patients. Finally, it ensures that Medicare recognizes the very best of medicine and the quality of our seniors' care increases because of it. After permanently repealing the SGR, Phase 1 of this framework gives providers a 5-year period of transition in which they will receive a baseline inflationary update of 0.5% per year, while the new Quality Update Incentive Program is developed and implemented. In Phase 2, beginning in 2019, providers will be eligible for a 1% update on top of the inflationary update based on their performance against quality measures and clinical practice improvement activities. The goal here is to take the best of medicine into the Medicare program and reward those who deliver it to seniors. Providers will also now have the choice to leave the fee-for-service Medicare payment system at any time to participate in an alternative payment model. While some of these models exist today, such as accountable care organizations, ACOs, or medical homes, this framework is flexible enough to accommodate new and innovative payment models that arise in the future. We've also ensured that care coordination will be reimbursed with new payment coding opportunities for providers, and that Medicare data will be shared with providers and other entities so that we are continually improving quality and patient care. Finally, we've included a bipartisan liability provision that protects both doctors and patients in any malpractice claim. As we have with the previous drafts, we will continue to work to perfect this draft with public input as we move forward to full committee. I want to thank my friends on the other side of the aisle for their vital contributions to this product, and all the members of the committee who have weighed in with their thoughts and suggestions. I would also like to thank the entire subcommittee staff for their excellent work on this issue, and say a special thank you to Clay Alsbach, Robert Horn, Steve Ferrara, Katie Navaria, the staff of Dr. Burgess, and former committee staffer John O'Shea. Without their tireless efforts, this would not have been possible. With that, I yield back and recognize Congressman Green filling in for Ranking Member Pallone. 5 minutes for an opening statement.
Thank you, Mr. Chairman, for holding a markup on this bipartisan draft. Repealing and replacing the SGR should be a top priority of this committee and this Congress. The SGR creates uncertainty for providers and beneficiaries and bogs Congress down with the annual doc fix legislation. We need to move past this flawed system. I think the draft before us accomplishes this goal. Some have identified problems with specifics. For example, I think there needs to be additional rewards within primary care. That is not to say specialists should be drawing the short straw, but primary care plays a crucial role in our healthcare system, and we must do more to bolster their primary care workforce. I'm happy to hear that the chairman of the subcommittee and full committee, as well as ranking members, will address members' concerns as they come up. I think working in a bipartisan manner is necessary as we move this legislation. In this bill, while there is a new pathway for developing payment models, some have suggested that unless physicians see payment consequences, they will not willingly move to new models. On the other hand, if the models are attractive, physicians will want to participate. I think we need to make sure we hear views from all different sides on this issue and whether or not we're doing enough to move people to models that improve health care delivery without unnecessarily increasing cost. Another concern I have is what the bill does not do. Every year, part of the eventual legislative package that contains the SGR also includes what's called extenders. I hope the committee leadership continues their bipartisan work on these issues and that we make sure to address Medicare and Medicaid extenders at the appropriate point in the process. Finally, since it did not make it into the SGR draft, I support moving separately a bill, Mr. Whitfield and I, H.R. 800, which would address another payment discrepancy in Medicare related to Part B drugs. I'm pleased with the direction this bill is taken. I look forward to working with the committee to finish it and move it to the House floor, and I yield back.
Chair thanks gentlemen. Now recognize the chairman of the full committee, Mr. Upton, for 5 minutes for his opening statement.
Well, thank you, Mr. Chairman. This afternoon, we're going to start considering important bipartisan legislation to repeal the Sustainable Growth Rate, SGR, and replace it with a stable and fair payment policy that indeed puts seniors and their doctors first. This legislation is over 15 years in the making, as the highly flawed SGR has frustrated patients, doctors, and lawmakers alike since its first passage back in 1997. SGR has threatened Medicare annually, sometimes monthly, with large pay cuts that has hobbled physicians' ability to run their practices and, more importantly, distracted them from their top priority of caring for patients. Similarly, the uncertainty of whether doctors can afford to keep their doors open places seniors at real risk of losing access to their trusted physician. I'm proud to say that this legislation that we're making demonstrates great progress towards correcting many of these flaws and modernizing the physician benefit structure under Medicare. It provides a predictable payment structure for doctors, allowing them to focus on patients rather than payment. In doing so, it gives seniors the peace of mind of knowing that their physician will be there for them when they need them the most. And it modernizes the payment system by actually listening to the medical community's best practices and ensuring that the care patients receive is based on those best practices. And finally, it moves the Medicare system into alignment with the private sector, where innovative models of care that are patient-centered and coordinated have shown the ability to improve patient outcomes at lower cost. This policy is the culmination of work performed by the subcommittee throughout both the last and this Congress. Through the many hearings and collaborative efforts with stakeholders and our committee Democrats, we have crafted a promising bipartisan solution to the SGR. And during that process, we've had unprecedented engagement with the medical community across the board. Physicians across the country have been actively involved, and we welcome their continued contributions to this process. Last week, I met with a group of Michigan doctors who were very constructive in their input related to the opt-out provision included in the draft. This is an important process that has achieved a level of transparency that Americans expect and deserve, and one that can serve as a model for future legislative efforts. I want to particularly thank Ways and Means Chair Dave Camp for his partnership in the effort that we commenced over 2 years ago. I also want to commend Chairman Pitts and Dr. Burgess for their leadership in drafting this policy, as well as recognize my colleagues on the other side of the aisle, especially Mr. Waxman, Mr. Pallone, and Mr. Dingle for their valuable contributions and indeed their support for this legislation. We've made great progress in achieving this milestone, but there is still a lot of work left in achieving fiscally responsible reform that puts the emphasis back where it belongs, on our patients and their doctors. Today is an important step in finishing the bipartisan work that we began well over 2 years ago, and I yield back the balance of my time.
Chair thanks the gentleman, and I now recognize the gentleman from California, Mr. Waxman, for 5 minutes for his opening statement.
Mr. Chairman, if you'll. Thank you, Mr. Chairman. Today we're taking an important step in addressing the failed method by which Medicare provider payment is determined, and I'm pleased to be part of this bipartisan effort to replace the sustainable growth rate, or SGR, formula that has resulted in the specter of large unsustainable cuts in payments every year, frustrating providers and beneficiaries alike. While we put in place with good intentions in the Balanced Budget Act of 1997, it's never provided the fiscal or programmatic stability that we need. I want to thank the chairman of the full committee and the subcommittee for the bipartisan spirit in which we have been working on this, and I think we all agree that the legislation coming out of our subcommittee is a much better product because of our collaborative efforts. This is a first step and an important one, but this is a process that has to start. We can't accept the current system any longer. We have bipartisan agreement on that, and I believe that the commitment to working together will serve us well. We know this is a work in progress. While we all agree on the problem, we also understand that our healthcare system is complex, and getting the right solution for both providers and beneficiaries is complicated. We share the priorities of wanting to move our payment system from one that rewards volume to one that aligns incentives and rewards quality, efficiency, and improved patient outcomes. We also want to build on the reform efforts already underway, innovation that is already taking place through new delivery and payment models like accountable care organizations and bundled payments, medical homes, and initiatives that boost primary care are already moving us in the direction of improved value in our healthcare system. This legislation takes an important next step. This legislation creates stability for the provider payment system. At the time, it supports greater accountability through quality measurement that not only looks at clinical processes of care and outcomes, but also patient experience and whether beneficiary needs are being met. The legislation also creates additional opportunities for providers to develop and participate in advanced payment models, engage in integrated approaches to coordinate care, and garner improved access to Medicare data to support those efforts. Last, this legislation supports primary care and care coordination through new payments for care coordination in patient-centered medical homes and patient-centered specialty practices. It is critical that we send a clear message and help to provide a clear path forward to a healthcare system whose hallmark is to provide the highest quality care. And that is what this legislation proposes to do. This legislation does not deal with other issues that we know Congress must address. For example, the annual extenders, like exemptions from caps on therapy services or funding for the Medicaid work transition program. That should not be cause for alarm, and I think our majority will agree. We intend to deal with those at the appropriate time. I look forward to continuing to work together with my colleagues on both sides of the aisle to reform payment system in Medicare in a way that continues to move our healthcare system toward better care at lower costs and better value for both taxpayers and beneficiaries. Thank you, Mr. Chairman. That completes my statement.
Chair.
Yield back the time.
Chair thanks the gentleman. The chair reminds members that pursuant to committee rules, all members' opening statements will be made part of the record. Are there further opening statements? Chair recognizes the Vice Chairman, Dr. Burgess, 3 minutes for opening statement.
Thank you, Mr. Chairman. Tomorrow, we'll get a chance to address what we have in a bipartisan fashion put forward as a legislative proposal to fully repeal the sustainable growth rate formula and improve Medicare for future beneficiaries. This includes creating another pathway to encourage innovation in Medicare to move more quickly and adapt to changes in practice and the delivery of health care services. However, if there's one thing that it is important to focus on today, it's the process by which all of this happened. This is the most transparent Medicare reform process undertaken by the committee, certainly at least during my 10-year tenure on the committee. We've solicited feedback from stakeholders at every step, hearing after hearing, including a legislative hearing in June. We've worked in consultation with our colleagues on Ways and Means. We released 2 white papers and 3 legislative drafts. Each time we received feedback, compiled helpful and realistic suggestions, and incorporated them into the final product. No one can say that they didn't know what we were doing. And during all of this, we kept talking. We talked almost every day for months. We did not let pay-fors lead the discussion. We knew that was the pathway to failure. We did focus on policy and indeed did the deep dive on policy. Because of that work, let's look at what has been accomplished so far. You repeal the SGR and provide a period of payment transition. We preserved fee-for-service. We have reduced an administrative burden by building off systems with which providers are already familiar. We encourage maximum alignment in regard to provider reporting. We put medicine in the driver's seat of working with the Center for Medicare and Medicaid Services to develop quality measures guided by best clinical practices. We allow individual practices to decide by which cohort of measures best aligns to their practice. We create an additional pathway to test models that enhance care and reduce cost. And yeah, I've used the word we a lot. That we means that it wasn't one individual or one political party, but it represents the bipartisan work of this committee. No one got everything they wanted, but we are all getting what we desire, moving forward a product that for far too long has failed to deal with the sustainable growth rate. There's still an enormous amount of work to do. We have not addressed every issue that we must, and I'll be working just as hard between now and full committee as we have up to now. And I will reiterate a promise that I have made multiple times to both members and other interested parties. I will continue to work with you if you bring reasonable suggestions to improve this product and move it forward and keep the bipartisan momentum going. Tomorrow will be an important day for Medicare beneficiaries, medicine, and for this committee. It's like the day before Christmas. It can't get here soon enough. I yield back, Mr. Chairman.
Chair thanks the gentleman. Now recognizes the ranking member emeritus, Mr. Dingle, 3 minutes for opening statement.
You are most kind, Mr. Chairman. I ask unanimous consent to revise and extend my remarks. I'm going to begin with a very small compliment. This is better than what we have now. But I hope my colleagues understand that that is said with great affection and with goodwill, because almost anything would be better than what we have now. The members have come forward with what I believe is a good thing, something which resolves to some degree, I hope, the awful problems which we've had with SGR, and something which I hope will lead us to speedy conclusion of the offering that they make to us today. I would hope, Mr. Chairman, that we move with all speed lest something go wrong and the wheels come off of this arrangement and we all of a sudden find out that we have not succeeded in making changes. It is my hope that we will find that the changes made in sustainable growth will be an example to us in doing better in the future and working together in a bipartisan fashion, the way this place should work in the public interest and in the interest of all of our people. So I congratulate my colleagues who have worked together on this. I commend them for what they have done. I look forward to working with them to resolving this legislation into a form where it can be signed by the President. And I hope that when we have completed this, we will commence on doing other things of equal merit and quality. Thank you, Mr. Chairman.
Chair thanks, gentlemen, and now recognize the gentleman from Texas, Mr. Barton, for 3 minutes for his opening statement.
Thank you, Mr. Chairman. For the last 10 or 15 years, we have known that the current SGR system doesn't work. You can go back to the early 2000s when Chairman Bliley was chairman, Chairman Tozan, Chairman Barton, Chairman Dingle, Chairman Waxman, and now Chairman Upton. There have been numerous times we have attempted on a bipartisan basis to repair, reform the SGR system, and they have, for various reasons, all broken down. So today we're starting on a new journey on a bipartisan basis. Mr. Pitts and Mr. Upton have worked with Mr. Dingle and Mr. Waxman and Mr. Pallone and others and come up with a replacement for the SGR, the current system. This bill before us has the advantage that it is telling the truth. The current system is broken. It cannot be fixed. This bill acknowledges that. It replaces the current system for 5 years with an update of 0.5% a year. That provides certainty and stability to the physician community. It creates an alternative payment trail or track based on incentives that physicians can opt into during that 5-year period. This gives the community a chance to determine what works and what doesn't work, and then move to hopefully an entirely new system that is yet to be developed. There are certain issues still to be dealt with at some point in time. We have to come up with a pay for, and that will not be easy. I think we need $139 billion over 10 years, but it's not an issue that cannot be dealt with at the appropriate time. So my hat's off to the leadership on both sides of the committee on this issue. I hope we have a cooperative subcommittee markup and full committee markup in due time. But I am a strong supporter that we need to reform the system, and I will be a strong yes vote when it comes time to vote out of the subcommittee the bill. And with that, Mr. Chairman, thank you for your leadership, and I yield back.
Chair thanks the gentleman, and now recognize the gentleman from New York, Mr. Engel, 3 minutes for opening statement.
Thank you, Mr. Chairman, and thank you for convening today's markup. I believe physicians deserve to be fairly and appropriately compensated for the important work they do. I think that is a given. The fact that SGR remains a looming problem each year has left physicians understandably frustrated, given the high cost of running a medical practice and the challenges associated with treating patients with increasingly complicated medical conditions. Physicians at the very least should have a sense of certainty regarding their Medicare reimbursement. Finding a solution to the SGR has always been difficult. Chairman Pitts, Chairman Upton, Ranking Member Pallone, Ranking Member Waxman, Chairman Emeritus Dingle, and Vice Chairman Burgess, I want to commend all of you on the hard work you've put into this draft legislation. While there is no such thing as a perfect bill that will satisfy everyone, the draft before us is a good framework that moves us closer to fairly compensating our Medicare physician workforce while incentivizing good quality care for our Medicare beneficiaries. However, I have a few concerns I'd like to mention. I represent in New York parts of the Bronx and Westchester County. I can drive from one end of my district to another in 30-35 minutes, and in the span of that half an hour, I will find myself in both some of the most affluent and also economically challenged areas of the country. Regardless of where they live, I think all of my constituents deserve to have access to high-quality health care. Therefore, I want to ensure proper risk adjustment is done within both the Quality Update Incentive Program and the alternative payment models to help account for the impact of socioeconomic factors in determining physician reimbursement under these programs. I want to see urban, suburban, and rural providers compensated by reimbursement methodologies that recognize the challenges associated with providing good health care for individuals who might lack stable housing, struggle with food scarcity, chronic unemployment, or lack adequate education to help ensure an adequate health care workforce, especially in high-need areas. Properly accounting for these challenges balancing the need to hold healthcare providers accountable, but recognizing outside factors may influence the health outcomes of patients who struggle is an important consideration in adequately reimbursing physicians. I would also like to voice my continued support for the various Medicaid and Medicare extenders, which have historically moved on the same bill as the annual doc fix. These extenders are very important to my constituents and healthcare providers in my district, and I want to see them addressed by this committee as well. And finally, I appreciate that this committee has taken the time to get the policy for Medicare physician reimbursement right, but I worry it will be a challenge to find appropriate offsets for this legislation. I will be voting in support of the draft before us today, but I want to encourage leadership on both sides of the aisle to reject poison pill offsets should this legislation go to the House floor for consideration. I want to see SGR repealed, but I will vote no on final passage if forced to by unpalatable offsets. So I thank the Chair and yield back the remainder of my time.
Chair, thanks, gentlemen, and now recognize the gentleman from Pennsylvania, Dr. Murphy, 3 minutes for opening statement.
Thank you, Mr. Chairman. We know that Medicare was written at a time when the most sophisticated equipment in a hospital was an X-ray machine. Although the program has been amended and changed countless times since then, it hasn't kept pace with advancements in the medical field. Medicare's flawed payment model reimburses for every poke, pull, and pinch of quality outcomes, but instead of quality outcomes. This system focuses on sickness and testing and has led to significant inefficiency and waste in nearly every private insurance product across the country. I'm pleased this bipartisan draft bill sets Medicare on a path to rewarding quality care. It advances a reform proposal that I've called for and worked on with this committee for several years, promoting clinical standards written and designed by doctors themselves. More than 150 medical specialty societies already write best practices and clinical guidelines for physicians to follow. However, our $2.4 trillion healthcare system, more than $600 billion is annually wasted due to inadequate and improper adherence to those clinical protocols. Those wasted procedures leave patients no healthier or happier. We want to ensure healthcare decisions are made by doctors and patients, not unqualified bureaucrats in Washington. This legislation puts doctors in the position of promoting the best practices and rewarding quality, whether it's adherence to clinical guidelines, using electronic medical records, or creating disease registries. The draft also addresses the problem of fragmented care. Traditional Medicare is buckling under the weight of chronic illness like diabetes, hypertension, and high cholesterol. Chronic illness now consumes 95% of Medicare's budget. In the last 15 years, nearly every dollar of increased Medicare spending can be traced to a higher number of beneficiaries with 5 or more chronic illnesses. As currently structured, Medicare is discouraging specialists from interacting with primary care physicians and others. This blindness to what other providers are doing is not just ineffective, it's downright dangerous for patients, and I'm encouraged to see the draft bill promotes a coordinated care system in medical homes. In coordinated care, doctors and nurses use evidence-based medicine to treat people with chronic illnesses like diabetes, hypertension, and congestive heart failure. Also called disease management, coordinated care ensures that patients follow through on prescriptions, therapies, lab work, diet treatments, and post-surgical care. For example, nurses help to keep diabetics' glucose levels in check, thereby avoiding costly complications. They also review to make sure the patient doesn't have other complications with vision, amputation, kidney failure, depression, etc. I look forward to continuing work on this with my colleagues on both sides of the aisle so we can deliver stability to physicians who will also be able to plan and budget and deliver peace of mind to seniors who won't have to worry about whether their doctors can no longer afford to accept Medicare. Thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. Recognize the gentlelady from the Virgin Islands, Dr. Christensen, 3 minutes for an opening statement.
Thank you, Mr. Chairman. I want to applaud and thank the committee leadership for this bipartisan bill and all of the input that went into it. The repeal of the sustainable growth rate has been a priority for all physicians for too long, as the cost of providing care far outstripped reimbursement years ago, and SGR has not been a factor that worked. The stopgap measures, while they prevented cuts, fixed nothing, created too much uncertainty, and thus threatened the care for Medicare beneficiaries. I'm a co-sponsor of the Medicare Physician Payment Innovation Act, but I agree that this is a great base bill that could be improved as we move toward passage. I'm pleased that the innovation of new models of care will continue. I practice family medicine, as you know, for over 20 years, and I'm glad that there's a recognition that fee-for-service can be a part of the mix in the beginning of the process, at least, because I believe that under the proposed update incentive program And with the improved payment accuracy also proposed in the legislation, fee-for-service might be able to work in this new environment and ought to be one of the payment models to be studied and improved as we move forward, along with medical home, ACOs, and all of the others. I also think that the National Medical Association, of which I have been a past regional chair and trustee, can support this legislation, with the caveat that as we develop methods for rewarding performance, provision is made to account for providers practicing in poor and rural communities with sicker patients and less services, so that we measure improvement and not just hold everyone to the same outcome levels, no matter the status of the patients or the community at the outset. As a family physician, I'm glad to see that the American Academy of Family Practice supports the bill, especially the proposed improvement in payment accuracy. But I agree with them that the bill could be improved with setting a higher base payment for services provided by primary care physicians. And I'd ask unanimous consent to enter the AAFP statement into the record.
Without objection, so ordered.
Thank you. And I look forward to working with the committee as this moves forward and want to ensure that there will be no impediment to physicians in our territories being fully included in all of the provisions of the final bill. I yield back the balance of my time, Mr. Chair.
Chair, thanks to the gentlelady. Now I recognize the gentleman from Louisiana, Dr. Cassidy, 3 minutes for opening statement.
Thank you, Mr. Chairman. As a practicing doc, on behalf of my medical colleagues, I am so pleased that the committee is eliminating the sustainable growth rate. The impact of the uncertainty created by the SGR is greatest upon those in solo practice or small group practices. These practices, again, will most appreciate this repeal. And by this I mean to say that independent practices, independent docs, went to med school to care for patients, not run businesses. An unfortunate side effect of current shared savings models is that these groups, these practices are forced into kind of a prisoner's bargain. You either go into a large shared saving program like an accountable care organization, or you continue to struggle in a fee-for-service system, which again has been threatened with SGR cuts. That is why I say these practices particularly benefit. However, it begs the notion that there should be some alternative to either joining a big ACO or continuing in the current fee-for-service, and I applaud this legislation for including alternative payment models. That said, I do think that policy should change and allow these smaller groups to participate in a risk-bearing option that allows them to remain in their current practices. To achieve this, they could privately contract with third-party entities that have a pre-established technology platform or other expertise that could facilitate care coordination and risk-bearing. The potential for such a model exists already. What is needed is the legal authority to leverage it. I appreciate the work of the committee in including the first steps towards this model in a bill. Liberating additional CMS data will go a long way towards fueling much-needed care coordination. I look forward to continuing to work in the committee with my other colleagues in Congress to fully develop an alternative payment model system that protects independent physician practices, allowing them to participate in the same payment innovation going on elsewhere. I also praise the bill for recognizing that for some patients, the specialist can be the principal physician caring for those with complex chronic diseases. I think this recognizes the reality in modern medicine. In closing, I thank those who drafted this bill, and I look forward at the end of the 113th Congress that we can truly say the sustainable growth rate is repealed. I yield back.
Chair, thanks, gentlemen. And now recognize the gentlelady from Florida, Miss Castor, 3 minutes for opening statement.
Well, thank you, Mr. Chairman. Colleagues, I think it's been clear for some time now that the way we pay doctors that serve Medicare patients is ripe for reform. So I'm very heartened that Republicans and Democrats have come together here in the Energy and Commerce Committee to repeal the SGR and begin the necessary reforms. And when you take a step back, I think the overriding goal is that we must do everything possible to ensure that talented doctors continue to serve our older neighbors who rely on Medicare, especially as the population ages and the number of older Americans grows. Over the past decade, more and more Americans have come to recognize that the Medicare physician payment system that is based on the volume of care and not the value of care or quality is flawed. Paying doctors simply on a fee-for-service system without any measure of quality is outdated, and it has proven to be wasteful and expensive. But in this bipartisan bill, the committee creates a pathway to new reimbursement models that will treat providers fairly, improve patient outcomes, and reduce costs in Medicare by changing the way we pay physicians. The bill does this by incentivizing timely, evidence-based, coordinated care for Medicare beneficiaries, payment reforms that reimburse clinicians based on the basis of efficiency, quality, and patient outcomes are essential to slowing the rate of growth in healthcare spending while ensuring access to services. As the committee moves the bill forward, I encourage all stakeholders and experts to continue to weigh in so that we can continue to improve the bill. I'd like to examine whether or not we're doing enough on primary care. I think this could be an area of improvement by introducing more robust incentives for undervalued primary, preventative, and coordinated care services. But in any event, this bill is a good start on the path forward on comprehensive payment reform, strengthening Medicare, and a repeal of the SGR. Thank you, and I yield back.
Chair, thanks, gentlelady. Now recognize the gentlelady from Illinois, Miss Castor. 3 minutes for opening statement.
Thank you, Mr. Chairman. I am also just very pleased that we're working together in a bipartisan manner to address an issue that has plagued not only Congress, but physicians and their patients for the past decade. Each year, seniors and people with disabilities have feared that their health care provider would opt out of Medicare as the drastic SGR cuts loomed. To prevent the enormous access issues that would result if we allowed the SGR cut to go into effect, we passed a doc fix each year. We now have the opportunity to retire this annual ritual through the permanent repeal of the sustainable growth rate. And while I am very glad that we're working together to develop the policy to repeal the SGR, it's critical that we're also going to work together to identify pay-fors that do not simply shift costs to Medicare beneficiaries. As we all know, half of all Medicare beneficiaries make $22,500 or less, and they can't afford the burden of these additional costs. It would do Medicare beneficiaries no good if we repeal SGR and ensure their continued access to their health care providers if we pay for it by instituting increased costs on beneficiaries that actually then make it unaffordable for beneficiaries to see their health care providers for the health services that they need. And while I support the steps taken by this draft legislation to promote beneficiary access to health coordination in Medicare medical homes, I believe that we should do more. Currently, Medicare beneficiaries have access to a wide range of medical providers. By limiting the eligibility for reimbursement for care coordination in medical homes to doctors of medicine, MDs, and doctors of osteopathy, DOs, we limit access to these important services. We must expand this reimbursement to the full range of Medicare providers. While I'm glad that we're working to end the yearly need for a doc fix, it is important that we commit to permanently fixing other provisions in current law that limit access to care. One such provision is the cap on outpatient therapy services. Along with the yearly efforts to pass the doc fix each year, we also extend the exceptions process to the annual cap for all outpatient therapy services to ensure that Medicare beneficiaries have access to the therapy services that they need. We must commit to working together to repeal this arbitrary cap on therapy services and other provisions in current law that could prevent Americans from obtaining the health services that they need. And I yield back.
Chair, thanks, gentlelady. That concludes the opening statements of the members in attendance. The chair now calls up the committee print and asks the clerk to report.
Discussion draft to amend Title 18 of the Social Security Act to reform the sustainable growth rate and Medicare payment.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. For the information of members, we are now on the committee print, and the subcommittee will reconvene at 1:30 p.m. tomorrow afternoon I remind members that the chair will give priority recognition to amendments offered on a bipartisan basis. I look forward to seeing all of you tomorrow, and at this point, without objection, subcommittee stands in recess.